Hello everyone, my name is Shayanti with the UNM Division of Community Behavioral Health. Welcome to today's webinar presentation for the Community and Rural Psychiatry Residency Program webinar series. A few announcements before we get started. Please make sure your sound is muted during the presentation. If you have any question, please feel free to submit them in the chat or feel free to unmute yourself if Dr. Price opens the floor. For those requesting CE or Certificate of Completion, we will share an evaluation link in the chat towards the end of the presentation. To receive a certificate, you must attend the full presentation. Also, please note that you will have only 48 hours to complete the survey before the links becomes inactive. Without further delay, I hand it over to Dr. Price, and thank you very much once again for joining us today.
Okay. Hello, thank you so much for having me. I'm really excited to talk to you about one of my favorite psychiatry topics, which is psychiatric toxidromes. They asked me to include a brief bio. I'm not really great about talking about myself. And so I'm just going to say that I obtained my Ph.D. in Biomedical Sciences before I started medical school. I'm currently in my second year of Psychiatry Residency here at UNM, and I really love working with our patients here in New Mexico. Here's some information about completing your continuing education credits, and there will be a slide at the end to further pursue those. Just want to let you know that I have no financial arrangements related to the content of this activity, and that the views expressed in this presentation are my own, and they don't represent the views, policies, or positions of the University of New Mexico. So to begin this presentation, I wanted to use learning objectives to create a blueprint of what we're going to talk about today. By the end of this presentation, we should be able to identify different psychiatric toxidromes using some fun clinical cases that I've put together. Secondly, we should be able to contrast different toxidrome symptomatology in terms of patterns and receptors in the body and the brain. And lastly, we should be able to predict the acuity of different toxidrome presentations and name therapeutic interventions as appropriate. Before we get started with the clinical cases, I think it's useful to go over some definitions. Some of these slides I wanted to say are directly inspired by one of the first presentations I had on toxicology and toxidromes from Dr. Emiliano Valles, who's a mentor of mine and also a UNM clinical liaison psychiatrist. So when we talk about toxicology, specifically we're talking about the study of or the clinical specialty of caring for someone who has an illness related to an exposure to any exogenous substance. However, a toxidrome is a constellation or a pattern of findings or symptoms in a patient that result from a very particular poison. Thus, it's a pattern of symptoms that can lead to or suggest a particular intoxicant. Importantly, when we're talking about toxidromes and patients, we know that they're often very ill. They commonly have a bunch of neuropsychiatric symptoms on physical exam. They commonly display a waxing and waning cognition, suggesting a state of delirium. And they often have adverse side effects that we have to manage. Further definitions, toxicity is the degree to which a substance can damage an organism. So the higher the toxicity, the more damage it's going to do to the patient. A toxin is a biologically produced poison. So peptides, proteins, small molecules. I like to think of LPS in bacteria. Toxicant includes any substance made by humans, and these can be further broken down into different categories, such as chemical, lead, mercury, or it can be medications. Biological, so these would be viruses or bacteria grown by humans, and then physical could be asbestos, coal, even water. And so one of the things I remember so clearly from that first presentation from Dr. Valles was a quote. And this quote is that any substance can be a medicine or a poison depending on the dose. And so that's really stuck with me. And so why do we need to care? Why do we need to be knowledgeable of toxidromes in psychiatry? And the answer is because we prescribe toxic substances to our patients. Additionally, our patients take toxic substances. Remember that any substance can be, any toxin can be a medication, but it can also be a poison. And so our patients are taking over-the-counter medications, they're taking dietary supplements, they use recreational substances. And then lastly, in psychiatry, sometimes our patients are trying to kill themselves. And so they're doing all of these things at the same time. And so psychiatrists need to know enough about toxicology to be able to make our own assessments and to recognize a toxidrome when a patient comes in very ill. And so when a patient comes into our clinic or our facility with toxidrome symptomatology, workup should be as follows. Vitals are vital. I know it's a corny joke, but it's so true. On physical exam, you want to pay special attention to the eyes, specifically the pupils, the mucous membranes, the skin. GI symptomatology is really important. And of course, the nervous system. We need to do a neuro exam. Additionally, we want to do a really thorough mental status exam to assess how altered or how delirious our patient is. In terms of workup, I've listed some labs below that I think are particularly important in screening when a patient comes in with a toxidrome. Chemistry is really important, and we can assess whether the patient has an anion gap, acid-base status. If there's an osmolar gap, we want to get a blood glucose, liver function, specifically blood urea nitrogen, creatinine. We want to do arterial blood gas, creatinine kinase, urine drug screen, of course, and then tox studies. We're going to look and see if we can predict any particular toxins in the blood and see how high they are. Additionally, an EKG can be really helpful, as well as an abdominal film. And so if you recall, our second objective is to think about these toxidromes in terms of receptors and targets in the body and the brain. And this is just a really basic pictorial illustration of the different branches of the of the nervous system. And if you're like me, you don't think about these every day. So this may be a good reminder as to the differences between the different systems. Remembering that the sympathetic nervous system is in charge of our fight or flight response, and our parasympathetic nervous system is classically described as the rest and digest. You'll recall that both the sympathetic and the parasympathetic nervous systems use nicotinic receptors at the end of the preganglionic fiber. However, where they differ is the receptor at the end of the postganglionic fiber, which for the sympathetic nervous system is the adrenergic receptor versus the muscarinic receptor at the end of the at the end of the parasympathetic nervous system. This is a small but important difference because it results in very different responses in the different organs to different stimuli. And so if you look here on the right, you'll see some common effects of agonism of the or stimulation of the parasympathetic nerves or the sympathetic nerves. And so remembering that stimulation is going to produce these effects, but if we antagonize the system or decrease activation of either of these two nervous system branches, we're going to get the opposite effect. And so why does this matter? I think it's a useful way to think about symptom patterns in being able to predict when someone comes in with a toxidrome, to think backwards in terms of the symptom, the receptor target that may be causing that symptom, the toxin that binds that receptor, which is our end goal, right? If we can predict the toxin, then maybe we can give the appropriate antidote. So, for example, if a patient comes in with altered mental status, decreased respiratory drive, I may be concerned about the GABA receptor targets. But if I add to this constellation of symptoms pinpoint pupils, I may be considering the opioid receptor instead. And so with that, I thought we could jump into our first case. Hopefully you find these fun. I think they're kind of fun. So you're in clinic and a 17-year-old female presents to the hospital with somnolence, slurred speech, and confusion. She was found after she was going on a hike, reportedly mushroom foraging. Her skin is warm, flushed, and dry. Her mucous membranes are dry. Her pupils are dilated and they're not reactive to light on your light exam. And below you'll notice her vitals. And I thought we could just wait 15 or so seconds, and then I'll let you know what I think. Okay. And so hopefully you guessed that this is an anticholinergic toxidrome. And so anticholinergic is all about the muscarinic receptors. And so classically, when we think of an anticholinergic toxidrome, as you see in this picture on the right, we're worried about the little rhyme, hot as the desert, which is hyperthermia, blind as a bat, which is mydriasis, mad as a hatter, which is confusion or delirium, dry as a bone, specifically thinking about both dry mucous membranes, but also urinary retention. And then red as a beet, this is skin flushing. Other things we should think about or associate with this toxidrome are like a tremor and tachycardia. And so I've listed some of the common anticholinergic agents on the left. Specifically, I've seen this toxidrome with antihistamines, antipsychotics, and TCAs. And then I think it's important to remember that some less common medications can cause an anticholinergic response. And so these are things like urinary antispasmodics. And then, of course, here in New Mexico, I had to highlight plants and mushrooms, specifically Jimson weed. And so to treat an anticholinergic response, we need to give physiostigmine. And then, of course, we're going to give supportive care to our patients, specifically fluids. Okay, so we're done with our first case. We have several more. So case number 2. You've probably seen this next gentleman in your clinic or in the emergency room. He's a 43-year-old male with altered mental status. His wife reports that the altered mental status and kind of strange behavior started this afternoon after he was alone in his bedroom for several hours. Additionally, she notes that kind of recently in his subacute history, he's really been very irritable, which isn't like him for the last month. However, on your exam, the patient is completely confused. He's agitated. He's not following any of your commands. His pupils are dilated, and you have the vitals again below. I'd like you to specifically notice the tachycardia, the hyperthermia, and the hypertension. Again, I'll just give you about 15 seconds to think about what you think it could be. Okay, so let's see. So this is a sympathomimetic toxidrome. Again, here on the right, you'll notice a pictorial representation of some of the symptoms associated with this toxidrome. I want to highlight specifically the hypertension, the mydriasis, the tachycardia. And then there's all the things you would think of with a patient who's on a sympathomimetic drug of some sort. So sweating, agitation, and sometimes psychosis. Again, on the left, you'll see some common precipitants of this toxidrome, so cocaine, methamphetamine, bath salts, but remembering stimulants that we prescribe, methylphenidate and dextroamphetamine. So treatment is going to be benzodiazepines, which can help with both the sympathetic symptomatology, but they'll also help with the patient's agitation. Okay, case number 3. So for this case, we have a 30-year-old female who's brought to the hospital by her family. She's altered, she's been minimally responsive at home, and her family is really worried. She's diaphoretic and her pupils are constricted. She's been drooling. She's been incontinent of stool and urine. On physical exam, you auscultate her lung fields and you hear diffuse wheezing. Again, I'll have you notice her vitals below, specifically the bradycardia. Again, I'll just give you 15 seconds. Okay. And so this is a cholinergic response. So again, we're thinking about the muscarinic receptors. This time we have agonists of those muscarinic receptors. And so specifically, this patient let us know that there's a cholinergic toxidrome with the meiosis, so the pinpoint pupils, the sweating, and then I think of a cholinergic response as just leakiness everywhere, which sounds really horrible, but when you look at all of these symptoms, that's really what it is. They're crying, their nose is running, they're vomiting, they're incontinent of their bowels and their urine. Often they're salivating or drooling. And then the other thing to remember is that the heart is giving us this bradycardic rate. Classically, in test questions, the cholinergic toxidrome is caused by organophosphates, which bind the cholinesterase inhibitors. But it can also be caused by bothanicol, myasthenia gravis drugs, specifically pilocarpine, which can be eye drops, and then reportedly nicotine. I was reading, although that this is really just in small children. So in terms of treatment, we want to give respiratory support, right? These lungs are wet. The patient is rarely breathing very well. We're going to give atropine, which will help with a lot of the symptomatology, but it won't help with the muscle tremors. We're going to give prilidoxine to restore the acetylcholinesterase inhibitors. And then we want to do cardiac monitoring just because these patients are usually bradycardic. Okay. So for case number 4, this time we have a 42-year-old female with a history of major depressive disorder. It's been well managed on citalopram. They present to a follow-up visit with complaints of GI distress and anxiety, and then this weird new onset tremor. When you look at the patient on exam, you notice she's pretty diaphoretic. And the neuroexam is significant for some mild lower extremity hypertonicity and clonus. Medication review shows that she recently was started on an antibiotic for a mild infection. Vitals again are listed here below. And again, I'll just give you some time to think about what you think this could be. Okay. And so you probably guessed this one. This is serotonin syndrome. Importantly, serotonin syndrome appears to affect many organs in the body. Of course, that's because this receptor is throughout the body, including our brain, but also our GI tract. Patients are going to be confused. They're going to have nausea. They're going to have vomiting. They're going to have diarrhea. And then importantly, on neuroexam, you're going to see this hyperreflexia and clonus, which really should clue you into this being serotonin syndrome. So serotonin syndrome is often in the context of new antidepressants, new serotonin agonists, but we have to remember that some medications that we don't always think about are medications that interfere with some of our serotonergic drugs. And so here in this patient, it was an antibiotic, linezolid, which is actually a pretty, we don't prescribe it too often, but it is still used, as well as some antiemetics can interfere and even some headache medications. So importantly, to treat serotonin syndrome, the first and most important thing is to stop the medication. These patients often have to be transferred and admitted to the inpatient setting where they can be monitored and received some supportive therapy. Often benzodiazepines are utilized for agitation and tremor. And then cyproheptadine is also used. And that's because even though cyproheptadine is a histamine 1 receptor agonist, it actually has some 5-HT receptor affinity. So it does have some affinity for the serotonin receptor, and it can actually work by blocking these receptors. So, okay. So for case number 5, this is a 55-year-old male. He comes in with well-controlled bipolar disorder, and he's brought in by his wife for new acute altered mental status and sedation in the setting of what she thought was just a couple days of gastroenteritis. The patient, when you look at him, he's pale, he's sweating, he's drooling. His wife reports that he's been incontinent of urine and stool. And then his neck is strangely hyperextended on exam. And the more you look at him and do a neuroexam, you realize he's completely rigid on the muscular and tonicity exam of your neuroexam. So medication review is significant for recent metoclopramide prescription. Again, you'll see I've listed the vitals below, and I'll give you some time. All right. So again, you may have guessed this one. This is neuroleptic malignant syndrome. This is a feared side effect of neuroleptics and atypical antipsychotics. These patients typically present with tachycardia, hyperthermia, and tachypnea. They're almost always delirious, and of course, they present with this extreme rigidity in their muscles, classically noted as or called lead pipe rigidity. Again, on the left, you'll note some common precursors to this syndrome. Of course, we don't always remember that some antiemetics bind and block the dopamine receptor, and therefore they actually have the potential to cause neuroleptic malignancy. For treatment, again, the first and most important step is to stop the medication. These patients often have to be admitted to the ICU. There, they'll be given bromocriptine, which is a dopamine agonist, and amantadine to reverse dopamine depletion. Additionally, dantrolene can be given for muscle rigidity, and I was reading and learned that I guess ECT can help with temperature variability, cognition, and diaphoresis. I just threw in this slide to remind us of some of the other serious side effects of dopamine blockade, specifically extrapyramidal symptoms, including akathisia and acute dystonias. And of course, there's tardive dyskinesia, which can be irreversible if we don't decrease or remove that medication in time. Okay. So here is case number 5. This is an 18-year-old female. She's reporting depression and admits she took a bunch of pills at home today. She's not willing to tell you which pills she took. As you're talking to her, you realize she's pretty sweaty. She's nauseous. She's had several bouts of emesis. She's feeling a little bit shaky. Shortly after arrival, she starts to complain of a little bit of ringing in her ears before becoming a little altered and not really participating in questions anymore. Vitals are surprisingly normal. Again, I'll just give you 15 seconds. Okay. And so this is a Tylenol overdose. Recall that acetaminophen in toxic doses can produce hepatic necrosis, as the metabolite of acetaminophen, NAPQI, depletes glutathione in the liver. It leaves it subject to toxic tissue byproducts, specifically oxygen radicals, free radicals. Above, you'll see some of the substances that contain acetaminophen. And then on the right, you'll see that the toxicity of acetaminophen is often broken into 4 stages. During the first stage, which lasts anywhere from like 30 minutes or 30 minutes after ingestion to 24 hours, the patient's often asymptomatic. They could have some mild emesis and tinnitus like our patient did, but they could also be completely asymptomatic. In the second stage, which often starts anywhere from 18 hours and goes to 72 hours, there may be emesis. There's often right upper quadrant pain and then hypotension. The third stage is defined at 72 hours to 96 hours, and this is when the liver becomes truly dysfunctional. The patient develops renal failure, acidosis, and encephalopathy, all at the same time. Death usually occurs at this stage. And then the last stage, which we won't talk about, is recovery. And so treatment is often supportive care. We have to admit these patients, they need their labs monitored. Specifically, we need to monitor LFTs to see how badly the liver is damaged. We're going to monitor acetaminophen levels as they decrease. And we're also going to monitor, kidney function as well. Importantly, N-acetylcysteine is given to regenerate the glutathione and to hopefully reverse some of the damage. Okay. So case number 6. So for this case, you're no longer in clinic. You've been given a day off and you're out enjoying your day off. When you come across a 24-year-old male who's found down and unresponsive. His friend is with him and reports that earlier this evening at a party, the patient took a handful of blue pills. His pupils are about 3 millimeters, and then his vitals are below. If you're like me, the first thing you notice is his bradycardia, his respiratory rate, and then that really low blood pressure. And then you know the drill. I'll give you just 15 seconds to think about what you think this is. All right. So this is an opioid overdose. The toxidrome for opioids, again, shown in this picture on the right, is altered mental status, somnolence, decreased respiratory rate, hypotension, sometimes hypothermia. Importantly, in these patients, you may want to do some testing for rhabdomyolysis, depending on how long they've been, down. And then just as a side note, I know we did definitions earlier, but here are just a couple more. So on the left, we see common causes of the opioid toxidrome. These include opiates, opioids, and tramadol. And so opiates refer to natural opioids such as heroin, morphine, and codeine. Opioids refer to everything, so all natural, semi-synthetic, and synthetic opioids. Treatment is going to be with opioid competitive antagonists, specifically naloxone or nalmefene. These medications will often wake the patient up and make them extremely grumpy as they initiate withdrawal. All right, and so we've made it to our very last case, case number 7. Here we have a 62-year-old female. She presents to your clinic with concern over a new tremor and muscle weakness. Her daughter's been really worried about her. She says very recently that her mother's been more confused. She even uses the word dementia once or twice. She's really worried about her cognition, and so she brought her into clinic today. The patient reports that the only real medication change has been a recent prescription for endomethacin for arthritis, but no other new medications. In fact, this patient has been stable on the same medications for her bipolar disorder and her anxiety for many years. No vitals on this one. I'll just give you guys 15 seconds. Okay. And so this is a toxidrome alluding to a lithium overdose or lithium toxicity. I actually just had a patient come into PES with this a couple weeks ago. The same exact case, actually. So as you know, lithium has a very narrow window of efficacy. And so when it exceeds the upper end of this window, it can cause nausea, tremors. It can make a person psychotic or altered. It can cause kidney disease, syncope, dehydration, and then sadly, it can cause coma and occasionally death. Lithium carbonate and lithium citrate are the main culprits here. However, it's important to remember with these medications that other medications that the patient takes can alter the metabolism of the lithium, thereby increasing or decreasing the concentration of the medication in the body, as with our patient here. And so this patient was recently prescribed endomethacin, and we know that NSAIDs can actually slow clearance of lithium. And so really the only treatment for a lithium overdose is dialysis or continuous renal replacement therapy. We just have to remove that small ion from the body. Of course, the patient should also receive supportive therapy as well. They should just be admitted for monitoring. Okay. And so that's all of the cases I have for today. But I wanted to end by just putting this slide up. This is another slide that Dr. Vyas shared with me. And this is just a slide showing how long different medications are detectable in the urine. Importantly, it also talks about medications that'll give false positive for these medications. So importantly, amphetamines can have a false positive with bupropion or Wellbutrin, trazodone, as well as amantadine. THC can have false positives with ibuprofen and naproxen. And then opiates, I had heard about poppy seeds, but I don't think everyone knows that also rifampin can give a false positive. Rifampin's just an old TB drug, but it is still used. It's actually one of the mainstays of treatment, and so that can also cause a false positive. And so with that, I thank you all for coming to my talk today. I hope you found this presentation interesting, maybe even a little fun in terms of the clinical cases, and I really appreciate your attention. Here are my references, and then here's the evaluation link. Thank you so much, and with that, I'll happily take any questions that you may have.